Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Drew Remignanti. He's an emergency physician. We're going to talk about his book, The Healing Connection, A Partnership for Your Health. Drew, welcome back to the show.
Thanks a lot for having me, Kevin.
So we were talking, you were last on about a year and a half ago. For those who didn't listen to our first episode together, just briefly again, share your story and journey.
Well, I'm not actually now a retired emergency physician. I retired as of April of 20, which put me at 40 years of a career. And I chose that not because of the pandemic, but because I was getting on. And it was convenient timing because I got to leave the emergency department during the pandemic while I was on a couple of immunosuppressive medicines.
Yeah.
Because in addition to having a 40-year career in emergency medicine, I've had a 50-year career as a chronic disease patient with an autoimmune disease. Unfortunately, that career doesn't offer retirement options, so I was able to retire from work, but not from being a patient. So I wrote the book as a series of reflections and insights I've gained over those 40 and 50-year careers. Interestingly, had a little mini reunion with a half a dozen medical school classmates, and we're all commiserating about the fact that it feels like the corporate takeover of medicine happened on our watch. And it's happening in a way that I think many patients are really not even aware of, the degree to which dollar-driven decision-making is driving what happens in the office between you and your physician. And I think we need to try to put a halt to that. And so I've written a book, try to begin a conversation about how do we halt that process.
So before going more into detail of that, you mentioned that you've been an emergency physician for 40 years now, and I know that you've seen a lot of corporate influences specifically with emergency medicine. Now, tell us a little bit more about that evolution over the decades in emergency medicine.
Well, the way that manifests, I started my career as a single doctor in a moderate-sized emergency department. When we were trained, we were told you need to be efficient in your practice because you need to be aware of what's going on in the entire department. But the idea that we should need to be productive was never mentioned. And so I'm offended. What's happening in healthcare now is the patient-physician relationship is rapidly being converted into a consumer-provider relationship. And I'm offended by being considered a consumer rather than a patient, and I'm offended by being considered a provider rather than a fully trained physician. Basically, what happens on a day-to-day basis is we're told to see more patients, see them faster, keep them more satisfied, and oh, by the way, don't make any mistakes. It's really only the last one that I'm worried about.
So when you were talking about those competing pressures, see them faster, don't make any mistakes, maintain high patient satisfaction scores, how does that influence you as a physician? How does that make you feel emotionally practicing emergency medicine in that environment?
Well, it was extremely stressful, and it added to the term burnout is being used. I like the alternative term that Dean and Talbot brought up, which is moral injury. Basically, you're being forced to make rapid decisions in a setting in which you don't think rapid decisions are in the patient's best interest. And so I think as physicians, what we need to do is we need to establish what we think is required to have the proper interaction with our patients and adhere to our own values that we've developed over the course of our career. But you're constantly being pressured to say, no, that's not right. You need to get on to the next person, get on to the next person, get on to the next person. And time is really the most value in a patient-physician interaction, the time you can take to communicate. We're in a setting now where high tech is ruling in medicine, in emergency medicine a lot, but all of medicine, high tech is what everybody's excited about. And what we're losing sight of is that we need a high touch and a high talk environment also. Getting to the proper diagnosis and arranging the proper treatment plan for a patient requires the time to converse and get to know each other.
Now, we talked about the effects of that on physicians, specifically moral injury and some would say burnout. How about the patients? How do these competing pressures that a lot of physicians experience, how does that affect patients today?
Well, I think patients are in the moment, they're satisfied if they can get things done in an efficient and convenient fashion. I am too when I'm a patient. I like convenience as much as anybody, but I think they don't understand that the convenience of getting in and out with someone who doesn't know you is not as valuable as spending more time with somebody who does. In my book, I have over 280 references. I'm going to just hold up the book for. And one of the things I've pointed out repeatedly is that as patients, if we know our doctor well and we can trust our doctor, that helps us. And even more importantly, if we feel known by our doctor, we're more likely to become engaged in the planning of our treatment plan, and then we're more likely to adhere to carrying it out. So you have to have that engagement with somebody who knows you. The downside of the emergency department is I'm usually meeting people for the first time, sometimes repeat visitors, and we try to establish a useful exchange as quickly as we can, but it's primary care is really what we need to incentivize more in the US healthcare system.
So your book is called The Healing Connection, a partnership for your health. You mentioned this book has many, many reflections over your decades-long career as an emergency physician. Tell us some of the main themes and messages that go throughout your book.
What's interesting when I started to do the research is how strong the science is behind the utility of having that kind of a fully engaged partnership. Really, study after study, I quote 5 or 6 of them in the book, show that it can cut our mortality rate risk in half. If those studies had come to conclusions that maybe it's a 5 or 10% reduction in mortality rate risk, you'd say, so what? That's nice. But literally in half, you're half as likely to die if you are more knowledgeable, more engaged patient. And because those people who are more knowledgeable and more engaged in the planning of their treatment plan in partnership with their doctor are more likely to follow through with that plan. I would say to folks, next time you're in your doctor's office, you say to yourself, when I leave here, I'm going to have to do everything that my doctor and I decided we're going to do. And if you went in with that expectation that you're going to have to do it, you're making a commitment to do it, you would ask the questions that you need to ask while you're there in the office. You wouldn't do what I think a lot of people do, is in the back of the mind, they're saying, yeah, there's no way I'm going to do that.
So when you say patients need to be more engaged in their own healthcare, what exactly does that look like? What do patients have to do going into a primary care office to be more engaged?
Well, I think I'm a big supporter of the idea that people need to advocate for themselves, but that I think some people are distorting that into the idea that they can become their own doctor, and your healthcare is really not amenable to being a do-it-yourself project, because we can become very knowledgeable as patients, but we cannot develop the degree of insight that a medical education delivers to us, and then all the years of practice thereafter. So I would say to patients, don't take anything as a piece of advice from your physician without questioning it. You can question it internally, and then you need to overtly ask those questions. You said, I need to do this. Do I really need to do that? I fortunately have the advantage when I'm seeing my doctor for my chronic condition. He can tell me things like, gee, Drew, we're going to try on this medicine for the next 6 months. We're not really sure it works, he said to me honestly, which was kind of, and if you have that kind of relationship with your doctor, you can get over those hurdles, which is, okay, this one is going to potentially cause these side effects. Let me know if those side effects become unbearable for you. And if they are, we can switch to something else. But if they're not, let's give this a 6-month try. So you need to have I call it a partnership, and that's not an equal partnership because we have different strengths. The patient's strength is knowing what their concerns are, knowing what they're feeling, and they need to try to take the time to convey that to us accurately as physicians. And the physicians and what goals they want to achieve with their healthcare. The physician side, we have the expertise of knowing how best to get you where you want to be and what the risks are.
So I talk to some patients and they say that they have so many resources that's available to them. Of course, there's everything on Google, but now we have artificial intelligence, we have ChatGPT where they can just simply ask questions and have plausible answers come back to them. Maybe you could give us an example of how that partnership with a physician can be more important than patients just looking stuff up on artificial intelligence tools and Google.
I go in the book, I go into issues like bias and denial that we can have as patients, and too much information to summarize here, but you need to be a fully engaged individual in that interaction. You cannot take a passive role, the old time passive role where the paternalistic attitude we took as physicians and said, and we adopted that as patients as well. I'm just going to go in there and wait to be told what I have to do. We have to abandon that, but we can't replace it by the idea that as a patient, I'm correct and the doctor can't possibly be correct. I refer to it as rejiggering it into a parentalistic relationship. I have a parental type concern about you as a patient. I'm not going to treat you like a child, but I'm going to have that degree of concern about you. I want you to have that same degree of concern about our interaction. You come in thinking, gee, this is very important. And I think people don't, they don't make that degree of commitment. And we can do it. I mean, tomorrow, I'm overnight tonight. You could decide the next time in my doctor's office, I'm going to say this to my doctor. I've decided to become a much more knowledgeable and engaged patient in our interactions. So I'm going to be asking a lot more questions. You'll have to take a pause at that moment and help your doctor back up off the floor into their chair because they'll have passed out at the. We're desperate. I think we're desperate as physicians to get patients that engaged in what's going on, and we're ready for it. Some of us are not. And if you find your doctor can't work with you that way, it's time to look for another doctor, I think.
Now, we talk a lot about the decline in primary care. I'm a primary care and internal medicine physician myself. It takes patients 6 to 9 months to see me for a new appointment. And we both know that medical students today are shunning primary care for specialties. So, how can patients develop long-term relationships with primary care if there's just not enough capacity in the system?
Yeah, we need. I almost went into that in my book, but one of the comments I make in my book is you should, I'm not an expert in economics, so I declined to go there because it would take probably twice as many pages. 360 pages would become 700 pages. But there's no doubt that we need to incentivize primary care for medical students and physicians to choose as a specialty. And we need to probably do things like reduce their medical school debt, which is almost 10 times as much as it was now as it was when I graduated in 1980. So those are things we can do as a society. We can't do them as individual patients, but I think we need to incentivize people going into primary care. We need to incentivize patients for putting more trust in primary care. And the argument I make repeatedly through my book, there's a lot to be gained by that simple connection. That's why I call it a healing connection. That connection with somebody who knows you best we're not error free if we know each other well, but we have much more likelihood of coming to good treatment plan for you, and you have much more of a likelihood of following through on that treatment plan. There are no panaceas, and you know that, but we need to incentivize primary care in whatever ways we can. If I was the grand guru in charge of all of medicine, I would increase the rate of primary care physician pay by 50% overnight. I wouldn't take it from the specialist physicians, but I would say, let's respect what the primary care physician does. The primary care physicians, internal medicine, family practice, and pediatricians are the least well-paid specialties. And yet I think they probably are in the most important role for most of what we suffer from as patients.
We're talking to Drew Remignanti. He's an emergency physician, and we've been talking about his book, The Healing Connection, A Partnership for Your Health. Drew, for the patients listening to this, and we're all patients, tell us some of your highest yield tips that you could share with them to make patients more engaged like you want them to be.
As I keep saying, you have to think, of course, you're at the doctor because you're worried about your health. You need to convey what those worries are. But you need to go in with the idea we're both committed to my health. And at that moment, the doctor, of course, is committed to a number of other people's health. And if you go in with that feeling that I'm not going to tell the doctor what to do, but I won't sit here passively and be told what to do without questioning everything. And again, with the idea in mind that once that give and take happens with your physician, don't leave the room unless you've had the chance to ask your questions. You might have to reschedule for another visit, or you might say, gee, next time, can I have 2 slots? Because I have a lot of questions that we haven't gone over. And of course, if we have the time and energy to do more reading on our own and not just the internet, because there's good information there and there's just misleading information as well. If you're an unlucky person, you might have more commonly, you might have 1 or 2 chronic disease conditions. If you're unlucky, you might have 2 or 3, or God forbid, 4. You need to become a mini expert on your medical conditions, reading as much as you can about, say, high blood pressure, what's most effective in treating high blood pressure, so you can have a higher level discussion with your doctor when you're in there. Yes, it's going to take some effort, but it will pay off. One of the articles I quote in my book showed that in the US, we have only about 12% of U.S. adults are considered healthcare literate, and that they're knowledgeable enough to know how to obtain and process and understand medical information. We don't do a good job educating people through, grammar school, middle school, high school, college about healthcare. So we need to do a better job of that. Now, these are not people who are illiterate and can't read, because they're illiterate people who just decide that healthcare is a subject I don't need to know much about because I'm going to rely on my doctor. That has to change. Yes, this is a subject you do need to know a lot about. And if it's 2 or 3 conditions, high blood pressure, diabetes, high cholesterol level, most people who can read can get fairly knowledgeable about that if they put the time and effort in, I believe.
And my final question, Drew, tell us some of your take-home messages that you want to leave for the Kevin MD audience.
And besides obviously reading my book, I would love it if you buy my book, but get it from the library. More important to me that you read the book and think about the content of it than that you necessarily buy it. Although it's an easy read. There's some hard slogs to it because there's a lot of data. I have over 280 references. The bulk of them are hypertext linked in the ebook version. But I put in enough there to keep the reader going along with case stories like the pericardiocentesis case, critically ill patients we've seen in the emergency department, but also less critically ill patients. So read and think about your health. And you don't need to know as much about medicine as Kevin and I do, because you're not going to have all those conditions that we're familiar with. And in the book, I talk about encountering patients with conditions I'd never heard of or treated before as well. But for the handful of conditions that you have, read. Ask questions. For conditions like high blood pressure and diabetes, for which diet plays a big role, you might decide with your doctor, gee, I'm going to have a consultation with the dietitian over at the hospital. So the doctor might say, well, gee, I can't spend the time to talk to you about how diet affects high blood pressure and diabetes, but the dietitian at the hospital can do that with you. So if you care about your health, and you should, and you want to spend days outside the hospital and cut your mortality rate risk in half, make a greater commitment to the process.
The book is called The Healing Connection, A Partnership for Your Health. Drew, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Kevin, thanks so much for having me on.